So welcome to this webinar. It's a topic that I'm really passionate about. You'll see on your screen a pretty little girl, and that is my daughter. Her name is Elena, and she is on the autism spectrum. And so I have focused my research and all of my coursework for my Doctor of Nursing practice degree on autism and the many things that go along with it. So I've been immersed in research for quite a while, trying to make things better for our children who are coming into the healthcare system and are autistic. And of course, it doesn't just start or stop with the child. We are seeing more and more adults coming into care who have autism. And so we need to make sure that as nurses, you have the information, at least basic information on autism and how to care for them when they're in the hospital setting. So as Susan said, my education, I have done my Bachelor of Science Nursing and my Master's of Nursing through Memorial University of Newfoundland, which is where I'm from. But I have worked in Saskatchewan for the last 10 years until I moved to New Brunswick in July of this last year for the Director of Nursing position. Okay. So the objectives today, at the end of today's presentation, you will understand what autism spectrum disorder is, understand the comorbid conditions associated with autism spectrum disorder, or ASD. And you'll hear me say ASD quite a bit, so that just means autism spectrum disorder. You'll be able to discuss how to reduce stimuli in the care setting, be able to discuss the importance of parent as expert in the child's care, understand ways to facilitate communication, and discuss ways to incorporate care effectively. So I'd like you all to think about for a moment what it is to be taking care of someone who is on the autism spectrum. I would like you to think about, have you ever cared for an individual with autism and what that experience was like for you? What were some challenges that you experienced, and what would you like to see implemented in your care area? Some of you may not have ever encountered anyone with autism and may not know the many different things that go along with the disorder. So I invite you to reflect on that as we go through the presentation. So as a healthcare provider in today's often fast-paced healthcare system, it really is important to be knowledgeable about those disorders that we're going to see and that commonly present to acute care and how to treat them effectively. Autism spectrum disorder is one of these disorders that you'll see more and more commonly in your practice. Each year, more and more children are being diagnosed, with 1 in 100 children being diagnosed worldwide. And in Canada, that number is even higher, with 1 in 58 children being diagnosed each year. So why is this significant for your practice? Because with each diagnosis, there is an increased likelihood of having to care for this vulnerable population. Autism spectrum disorder has its own unique traits that affect behavior, language, and socialization. Additionally, kids with autism often have multiple comorbidities that require medical care, meaning that you as practitioners will see more kids with autism than their neurotypical peers. So I'd like to just talk a little bit about what autism spectrum is. And so it's an umbrella term that encompasses several developmental disorders. These include Asperger's syndrome, autistic disorder, and pervasive developmental disorder not otherwise specified. And that's the acronym for that is PDD-NOS. These disorders are usually diagnosed in childhood, around the age of 18 months, when our children are developing their milestones that we tend to kind of gauge their abilities through. And so it's during that time, most children are diagnosed. However, that doesn't mean that you're not going to have people who are diagnosed later in life. We do have lots of people who are diagnosed in adulthood as well. And so a formal diagnosis is obtained when a clinical psychologist who's educated in the use of the DSM-5 TR performs an assessment that focuses on language use and acquisition, social interaction, restrictive and repetitive behaviors, and sensory disturbances. And since I've been doing my research, the DSM-5 has changed to now be the DSM-5 TR, which was published in 2022. There are a wide range of deficits that are associated with autism spectrum disorder, which is why the disorder is described as being on a spectrum. Some of the deficits include repetitive restrictive behaviors, such as flapping of hands or stimming, we call it, or head banging, inability to transition from one task to the next, little to no eye contact, preferences for solitary individual play, and unusual reactions to noise, taste, and smell. Children with ASD may also have difficulty with language acquisition and use. Some may be completely nonverbal, with only the utterance of sounds. Others may be very echolalic, and what echolalia means is when we repeat things over and over. So they repeat words, phrases, and sentences over and over again that they've either seen on television or through interaction with parents and siblings and those kinds of things. They will just repeat words. Their vocabulary is usually very big, but they don't use them in the right context. So they will often insert a word that doesn't make sense to what you're trying to figure out with them. My daughter was very echolalic. That's how we knew that there was something going on with her. When she was about 18 months was when she was diagnosed. She wasn't meeting her milestones like most typical children. And with her, it came in the form of regression. So she was talking very well. She was putting sentences together. And then all of a sudden she regressed, and she would just be repeating things that didn't make sense into the context of what the situation was. Of course, this repeating of words, phrases, and sentences can pose challenges for parents and caregivers because they may not be able to express their needs appropriately. And so that leads to frustration for parents and children, and often meltdowns. And so when we talk about a meltdown with autism spectrum disorder, it's not your typical temper tantrum that you would see in a neurotypical child. It's very different. In my experience, and I've experienced this quite a lot when she was little, she would have no concept of safety when she would be, overwhelmed, and she would scream, she would hit, and there was no way to calm her down. It was very, very difficult. I remember one time in particular where she had a meltdown, and it lasted for over 4 hours. And so as a parent, that is so difficult to be able to navigate and to keep your child safe when they have no sense of safety at that time. Lots of children with autism show marked behavioral, communication, and social difficulties. Others may show very little deficit. And it's usually in one of these or more areas. It can make treating a child with autism more difficult because each child is unique and brings unique challenges with them. However, there is a growing body of literature that supports the idea that early intervention and treatments tailored to each child's specific needs can lead to positive outcomes. As a provider of healthcare services, it is important to remember that each child's they need care, respect, and dignity despite these challenges that they face. Families often struggle with the challenges of caring for a child with special needs, and as such require supportive care as well. It's the healthcare provider's job then to ensure that both the child and the family have a team of knowledgeable, caring, and empathetic individuals who will advocate not only for the rights of the child, but the parent and caregiver as well. In addition to the range of difficulties experienced by children with autism, such as impaired social functioning, speech acquisition, and restrictive repetitive behaviors, many children also experience disturbances related to other areas of health and well-being. These can include depression, anxiety, schizophrenia, and bipolar disorder. Other comorbid conditions that affect children with ASD are seizure disorders, gastrointestinal problems, and frequent injuries. It's been reported that children with autism are more likely to access healthcare services than their typically developing peers, with nearly 13% of emergency department visits dedicated to mental health issues and 10% facing acute psychiatric difficulties requiring hospitalization before adulthood. Because of the associated comorbid conditions that these children face, there's an increased chance of health difficulty and the need to access acute care services. So for these reasons, it's really, really important that in order to best serve these children and their families and to promote positive experiences, that you as a caregiver has that information to be able to deal with the situation effectively. So this is my daughter, Elena. This was taken last November. And I have written on the screen here, if you've seen one child with autism, you've seen one child with autism. And so what does that mean? So I bet by looking at her that you would never guess that she has autism. And we've made significant progress in her developmental stages. She's now able to talk just as well as you or I. She has quite a large vocabulary. She's still echolalic. She'll still repeat things over and over again. But if you were to sit down with her, you would think, well, she's a little bit socially awkward, but she's, pretty normal. And so that can be a challenge because often these children, they look and on the surface like every other child. And so that poses a problem because unlike other syndromes, let's take, for example, Down syndrome, where there are characteristic facial features and things like that. Kids with autism don't have that. And so to anyone looking at the child who is experiencing a meltdown, let's say they're in a grocery store or wherever they are, people see them differently because they look normal. And so parents are treated differently as well. They're treated as if they are bad parents, that they're letting their child do things that they shouldn't. And so this range of ability with these children is really, really significant. And you can have one end of the spectrum where they're pretty normal, pretty, they talk well, they're interacting with other people. But then you also have the other side of the coin where they're nonverbal and just make noise. And so they communicate through the sounds that they make. So we kind of have to look at what that spectrum looks like. So Elena, when she was diagnosed, was considered moderately to severe on the autism spectrum. And she was diagnosed in the summer of 2013 when she was just little. And at the time of her diagnosis, she was, like I said, she was unable to talk. She was very echolalic. She couldn't hold a fork. She couldn't get dressed on her own. She was not fully potty trained until she was 5. She had restricted interests and played very well alone. So at 14, she's still not able to tie her shoes, no matter how hard I try. She has a hard time opening jars and bottles or packages and things like that. She just can't figure out how to turn the top of a bottle to open it. It's getting better, but the range of ability, as you can see just from that, is quite different than most 14-year-old kids. Most 14-year-old kids can tie their shoes and can open a bottle of pop or a bottle of juice or things like that. But she really does struggle with those things. We've done a ton of therapy. We've gone from constant stimming where she would shake her hands. She never ever head banged or anything like that. It was just her hands. And I had a conversation with her a couple of days ago, and I asked her about her stimming, and she said, "Mom, I've learned that I'm not allowed to do that anymore." And I said, "Is that hard?" And she says, "Well, I feel like it builds up, and then I have to get away and be able to do it in private, because it's not acceptable for me to do it while I'm in my classroom. It's not acceptable to do it when I'm out and we're grocery shopping or whatever the case is." So she said, "I just hold it in." She is very socially awkward. She now makes eye contact that I didn't ever think I was going to get. But she's told me that it's very difficult. And unless she's very familiar with the person and trusts them, she will not make eye contact. She's very funny. She has a very unique sense of humor. And she's just starting to grasp sarcasm. But it wasn't always like that. So she is the reason that I'm passionate about this topic. And we experienced something in the emergency room in Regina, Saskatchewan, when she was having trouble breathing. She had croup. It was a very traumatic experience that I'm happy to say that she's forgotten about, thank goodness. But it was a terrible experience. When we presented to the ER, I told the triage nurse that she was autistic and that she would be much better if she was placed in a semi-quiet space. Like, I know that you can't have complete quiet in a hospital, it's impossible. But we were told that there was nowhere to put her, so we had to sit in the noisy waiting room. And by the time we were placed in a room, Elena was already at the point of stimulation overload. And so I knew treatment was going to be very difficult. They tried to administer a mask to her, a Ventolin mask. But she was so wound up that she wouldn't keep still. I asked if I could administer the mask. I told them that I was a nurse, that I was a registered nurse, I was told no, they would not allow me to administer this mask. At this point, we were at the point of no return for her. She was screaming. She was trying to get away from the nurses. And it was decided that because she needed the mask so desperately, that they would have to mummy wrap her. So they wrapped her in a blanket to pin her arms and legs together. They made me sit behind her and put my arms around her to keep her still while they held the mask to her face. The mask had a puppy on it. It was a pediatric mask. And for years, she would say, "No puppy, Mom, no puppy," because she was scared of the hospital. And it wasn't until I was diagnosed with sleep apnea that she realized that masks were not something to be afraid of. She saw that Mommy wore a mask and that every night it didn't hurt me. I was okay. So, of course, now that she's older, she just needs explanation of what's going to happen, and then she's okay. But it took a very long time to get to this point. We're lucky. Many families have it so much harder, where even with age, they struggle every day. So I'm going to play a little video for you. It's called Carly's Cafe. And I want you to think about what it's like to be a neurotypical child and what Carly experiences.
I can't wait for a coffee. Oh, hello, barista.
What do you girls want?
Skim soy latte?
Taryn, soy can't be skim.
Hot chocolate? Orange juice?
No, Dad, I want a coffee. Hot chocolate? Great.
So I was thinking of going to Sarah's later. Could you give me a ride?
Yeah, sure. Are you cool with taking your sister?
Yeah.
Wait, what? I have my own plan.
Carly.
Okay, I'll see you tonight, okay?
Focus. Hey, sweetheart. It's okay. Carly, how can I help?
So this was Carly Fleischman. She was and still is nonverbal, but she found a way to be able to communicate through her computer. They had no idea that she was experiencing pain from a dental procedure that she had done. Her behavior had changed, but they didn't tie the two together. And so until she wrote on the computer. She typed it out, pain, mouth. And then they knew that just because she couldn't say the words, that she still was able to communicate. And so we often write these children off as not being able to understand, of not being intelligent, but they are very intelligent. On this screen here, you'll see a lady up in the corner here. Her name is Temple Grandin. She has a PhD. She's a doctor. I can't remember exactly what her PhD is in now, but it has something to do with cattle and how to humanely bring cows to slaughter. She figured out something that most neurotypical people couldn't. And she's been very, very successful. A very intelligent lady. Oops, there we go. So some strategies then to improve care. The first step in a hospital or acute care setting is to stop negative experiences before they happen. This can come in many forms, but for the autistic child who experiences marked changes in their perception of light, sound, smell, and taste, it can begin with the simplicity of reducing external stimuli. For the child with ASD, certain stimuli can elicit negative reactions. Some children describe excessive noise as painful or fearful, and then relief when the excess noise is reduced. My daughter actually wears a special type of earplug that lets in only a certain percentage of sound, so that when she's on the bus, she can tolerate the noise. When she's in music class, she can tolerate the music. And children, being children, not being able to play their instruments very well. So research has shown that noise levels exceed recommended guidelines and can have a negative impact on health outcomes of all patients, not just children with autism. Increased blood pressure, sleep disturbances, and decreased healing are some of the reported issues that are a result of increased noise levels in a hospital. And so this is true regardless of the presence of developmental disorders such as ASD. When parents and caregivers of children with ASD were asked about reduction of sensory stimulus during times that they had accessed care for their children within the Regina Capel Health region, 80% responded that no care was taken to reduce noise or sensory experiences in the provision of their care. Approximately 90% of parents and caregivers also said that they felt that additional education was warranted. Children with ASD often have difficulty with sensory overload. For many children, their senses are so acute that they may become overwhelmed with what many neurotypical children are able to handle with quite readily. This is especially true in the hospital or acute care setting, where the environment is one of efficiency and time restraint. We all know that things need to get done in a hospital. Healthcare personnel are buzzing around the unit with machines that beep, bright lights, raised voices, and this can spell disaster if the child is already on high alert, because they're the change of familiarity from home. Strange noises, along with odd smells, can be overwhelming for even neurotypical children. So imagine the impact of this on a child whose sense of hearing and smell is enhanced tenfold. Elena has the most acute hearing I've ever seen. She can hear something that's being whispered across the room. I didn't realize that until I was talking to her dad one night, and I just whispered something because I didn't want her to hear it. And she said, Mom, that's not true. I understood what you said. I heard you. And we were whispering. So I don't know how she managed to understand from that distance. However, the solution to this problem is relatively simple. Remove the child from the environment. And so to that, you think, well, how is that possible in a hospital emergency room? And that's a great point. You're right. It's impossible to completely eliminate the normal sounds that accompany the busyness of this type of setting. But it is possible to reduce the noises to an acceptable level. To effectively treat a child with ASD, assessment must begin when a child registers for care. Asking the parents or guardians if the child has ASD can trigger a focused assessment and expedite the triage process. Moving the child from the waiting room to an area that is quiet can set the stage for a positive encounter. The waiting room is one of the noisiest places in a hospital emergency department. So removing the child from this area quickly can help with the transition to an unfamiliar environment. Because bright lights are also bothersome to children with ASD, a room with lights that can be dimmed is probably the best if you can have it. And of course, sometimes it's necessary to have bright lighting in order for us to do our assessments. But warning before you turn on the lights can also ease the transition. Providing sunglasses may be something else that you want to consider. When triage has been completed and a child is moved to a waiting room, it's very important that they're placed in a private room as opposed to a semi-private or a ward. Sensory stimulation from the close proximity of other patients with varying health conditions and the noises associated with their care can be very bothersome. And of course, that then can lead to sensory overload. Other interventions for a child with autism experiencing sensory overload are just like the interventions used for any patient experiencing sensory overload. Reducing unwanted noise is as easy as removing unnecessary equipment from the room. Setting alarms on monitoring equipment to silent or low when appropriate is also beneficial. Taking the extra few minutes to set up the parameters on equipment to reflect the pediatric population can minimize the alarms on many monitoring systems. While not necessarily practical for all hospital departments, the delegation of a specific area or room that has minimal supplies, adjustable lighting, and neutral warm colors could be an option. The use of proper acoustical construction materials can reduce the amount of noise that is heard when room doors are closed. Removing all unnecessary equipment that can reduce anxieties, making the area more inviting and less institutional. Keeping in mind that not all visits to the emergency department are for life-threatening illnesses or conditions, much of the urgent care required of children could be performed in a room such as this. Continuity of care is also important, no matter the situation. This is especially important when providing care to children with autism, as building trust with new people is sometimes difficult. So when care is provided by a multitude of healthcare providers, the therapeutic relationship suffers as a child's need for routine and similarity is disrupted. Being unable to predict who the next person to walk into the room can be both unsettling and anxiety producing for the autistic child. And this can lead to sensory overload and possible emotional meltdown. And while this is not an exhaustive list of interventions to reduce stimuli in the acute care setting, these practical and easily implemented interventions can ease the sensory stimulation of children with ASD. This in turn then can reduce stress and anxiety and creates an environment that fosters positive health outcomes rather than negative experiences. So some strategies to improve care. We'll talk a little bit about each of these as we go through the rest of the presentation, but some of them are parent as expert, communication strategies, such as social stories, picture exchange, communication system, and visual schedules, distraction, the use of care plans, and the autism resource kit. While not true for every child with autism, most parents and caregivers are eager to learn about the condition and interventions to make life with ASD easier for their child and themselves. Based on conversations with parents of children with ASD, most know exactly the areas their child struggles in and how to make things better. They have researched different treatment modalities and have used every resource available to them. They have become experts in their child's care. They know what things trigger a meltdown, what things make the day go smoother, what things they have tried and failed, what things that they've tried and succeeded with. And as simple as it sounds, this is probably the one thing that has come up in conversation with parents the most. They feel their voice is not heard, yet they are willing and able to assist you in the care of their child. Asking a parent what can help in an already stressful situation helps build the therapeutic relationship and builds trust. Using suggestions made by parents can help foster trust with a child as well, because they are now familiar with the techniques that parents and caregivers already use with them. While handing over certain tasks and procedures in urgent or emergent situations is not possible or safe, and we understand that, taking the time to assess the situation to determine if treatment would be best delivered by the parent is really important. For example, administration of oral medications could be handed over to the parent or caregiver with proper education on how to do it, and may very well mean the difference between the child taking the medication or not. Another example is teaching the parent how to perform minor procedures, such as the administration of a medication via a nebulizer mask, which was the situation we were in. This type of procedure may be better tolerated if the child experiences this from someone they trust. Of course, this needs to be assessed on a situation by situation basis. If the parent is very stressed or the task is beyond parental learning, it may not be feasible, but it should be explored. Another type of strategy you can use is learning about the different communication styles and strategies. One is a social story. For many children with autism, communication is really difficult. And so they may be nonverbal while others use the echolalia, as I mentioned. Others still may only have very minor communication difficulties. And so this range of communication abilities makes pinpointing the correct and most effective method of communication difficult for healthcare providers, especially in an urgent or emergent situation. There are many different methods for communication, each with its own merit. But the underlying idea is that for communication to be successful for children with ASD, it must be kept simple. So social stories are another technique that can assist children with ASD to understand expectations, behaviors, and outcomes. These stories address a specific activity and the behavior that is expected when participating in that activity. Because these stories can be personalized, it gives the child a vested interest in how the story plays out. Of course, it's not realistic to think that for every child that presents to acute care that a personalized social story can be made to fit each child perfectly. However, we could use pre-scripted social stories with blanks left for personal information that can be developed beforehand and used as part of the ASD toolkit that you house on your specific unit. Stories depicting the most common treatments and procedures are a great resource that can be accessed immediately and require no preparation on behalf of the healthcare worker in the moment of care. However, making a social story is not quite as simple as it seems. There is a specific technique to it. A good social story that will accomplish behavioral change has to follow a certain strategy. And so making a social story, the first thing is to think about its purpose. If the goal is to teach the child to hold still while having blood work drawn, then we need to determine what the child will require to understand how to do this. For example, the child needs to understand that when they move around during a blood draw, it will hurt them more and could hurt the person trying to take the blood. So, but if they remain still, the procedure can be completed quickly and with minimal pain. To personalize the social story, the next step would include determining the child's likes and dislikes, as well as any fears they may have that you could incorporate into the social story. Personalization gives the child a frame of reference for the wanted behavior and kind of scripts them for the process that's about to happen. A social story is composed of different types of sentences that are presented in a specific order to achieve the intended goal. There are 7 types of sentences. These include descriptive sentences that answer the WH question, so who, what, when, where, and why. Perspective sentences that refer to feelings, opinions, and ideas. Directive sentences that offer suggestions to the specific behavior to be modified. Affirmative sentences that lets the child know that feeling a certain way is okay and not something to be ashamed of. There are cooperative sentences that show how others can help them achieve their goal. Control sentences that are written from the perspective of the autistic child, such as, I need to make sure I don't move because. And partial sentences that allow the reader to insert information into the story to allow personalization. These sentences are then presented in a manner that ensures that it remains positive and describes what should be done to accomplish the goal rather than what should not be done. Using graphics or other things such as photographs can aid in understanding, as many children are very visual learners. In addition, they may, if the outcome of a situation is not guaranteed, it's best to use language such as sometimes and usually. Social stories can be used very successfully to aid in providing a script for a child when they're in an unfamiliar situation. Preparation of those materials only takes a short time, but the benefits to children with ASD who present to the acute care can be monumental, and it can mean the difference between a positive or a negative healthcare experience. When Elena was little, she used to take her seatbelt off while I was driving on the highway. She figured out how to undo her 5-point harness in her car seat, and she would stand up in the van as we were moving. And so I would have to pull over and get her back in her seat and, you know, strapped in the way that she should be. So I made a social story that said, while mommy is driving the car, I have to sit in my seat. While mommy is driving the car, I can't stand up. And so I read that story to her every time we got in the car. I read it to her before we left, and I've read it to her on the way home before we got in the car. And it took about 6 weeks of doing that every day, because I was working in Regina and living in another community, so I was commuting. But I was able to then show her what the expectation is when you're driving and the safety part of it. So the Picture Exchange Communication System, or PECS, is a system of communication used for children and adults with ASD who are nonverbal or have great difficulty with spoken language. Developed in 1984 by Laurie Frost and Dr. Andrew Bondi, the PEC system provides a means for individuals to communicate non-verbally through the use of various descriptive pictures. The system is widely used in the autism community and has changed significantly over the years to include computerized application systems, making the system very accessible. These tools could make up a portion of any acute care area and could be put in the autism resource kit that you have on your unit. It can be purchased from a variety of sources. Access to these resources could be facilitated by your local autism resource center. With some creativity and a little time, the most common medical procedures can be explained in pictures rather than words. This visual representation allows the child the time to internalize the information and prepare for what is expected of them. The next is visual schedules. These are based on the same idea as the PEC system. Visual representation of an idea that can facilitate communication. Many children with autism are visual learners, and so having a visual schedule of the day's events or a visual sequence of events can aid in understanding and reduce the chance of fear associated with the unknown. Being able to see what comes next can alleviate stress and increase the child's comfort. These can be easily developed with the use of a whiteboard, Velcro, and laminated pictures, and can be customized to reflect normal routines of a pediatric unit or the sequence of events that will occur while in the acute care setting. Today, you would see most of these things in an electronic form, but these visual schedules themselves are really easy to make and take minimal time in the morning to really show the child what is expected of them for the day. They understand that, you know, they get up in the morning at 7 o'clock, they go to school at 8, they come home from school at 2:30, they have a snack, they do their homework. All of these things laid out for them can make those transitions easier. Another technique is distraction. It can be used alone or in combination with other techniques. Distraction is not a new concept, but one that is often underutilized, particularly with children with ASD. Through discussion with the parents and caregivers, it's possible to modify care to include things that the child enjoys, such as coloring or bubbles, to provide much needed distraction from tests, procedures, or assessments. Distraction is used commonly in the care of children, especially when performing potentially painful procedures, regardless of diagnosis. Children without any type of diagnosis, we use distraction to try to help them through those things. And so it can include getting the child to focus on external stimuli, such as a stuffed animal or bubbles, but can be used with the child performing certain tasks. So for example, getting the child to inflate a balloon or sing a song allows the child to focus on the task rather than the intervention being performed. To ensure that this is successful, assessment data needs to be collected to ensure that the reward or distraction is specific to the child's likes and dislikes. And so this can be obtained from the parent or caregiver. The use of individualized care plans are not a new idea in healthcare and is something that is routinely used within most health regions. However, these documents are not shared with individuals outside of the immediate care team for confidentiality reasons. In the case of families with a child with autism, the use of a care plan that could be given to parents or caregivers to present to healthcare services when they come in could take the guesswork out of provision of quality care. In areas where ongoing care is provided by a team of pediatric specialists at one facility, this may not be necessary. However, the lack of a specialized pediatric hospital in Regina, where I was living, suggests that this could prove to be a very valuable tool. Interventions that have proved successful in the provision of care for the child are recorded and updated regularly with input from all the team members as well as the family and caregivers, and can increase positive outcomes. The Autism Resource Kit is a really great thing to have on your unit. These things can be made very easily or bought at a dollar store, and things that can be used every day with kids, and they love them. They love these things. Anything that has a different kind of texture or feeling to it, like those little monsters on the screen here, they feel very rubbery, and so the little spikes on them has a kind of a different feel, and so that can provide distraction. You'll see the little boy, he's chewing on what we call a cool chew. If you're going to use something that the child is going to chew on, because lots of times kids with autism have a sensory deficit where they need to put things in their mouth, and so they'll often chew on their clothing, or they'll chew on you know, anything they can get their hands on, really. So having things that are safe and durable so that pieces don't come off is really important. So as a healthcare provider, it's a good idea to develop an autism resource kit for your unit. It can include social stories, visual schedules, PECS cards, pertaining to the most common medical treatments of your area. The kit can also include sensory stimulation toys and activities such as spin tops or stress balls, chew pendants, weighted blankets, vests, and easy to make sensory bottles. So you'll see in the middle of the screen here some sensory bottles. You have glitter and water in one bottle, and it's sealed, so it's glued together so you can't get it open. And just the movement and watching the glitter move in the tube provides distraction for the child. Another great tool that could be included in the resource kit could be ear defenders. So a couple of slides back, there were what looked like headphones that kind of like what I'm wearing right now. But they're made specifically for kids with autism, and they drown out the noise. So like Elena, she could wear her ear defenders when she was little, and I could talk in a normal tone of voice and she could still hear me, no problem. So if she could still hear me, no problem, while wearing earphones or ear muffs or whatever you want to call them, imagine what the sound is like for her every day. So provision of quality care starts with qualified and highly educated healthcare workers. It is an expectation that everyone, regardless of ability, intellect, social class, or race, receives quality care when they're accessing healthcare services. This is also true of children and their families who are dealing with autism, but little is done to actually make the provision of healthcare a positive experience for those with sensory issues and developmental delay. Each person is treated the same as the next, regardless of their diagnosis. And while this is great for promoting equality, can be detrimental to how a child with ASD perceives the healthcare environment. So through education and some strategically implemented interventions, these families can be assured that the care that you give is tailored to the special needs of their children. Reduction of stress and sensory overload has a positive impact not only on the children, but the family as a whole. Unfortunately, families that deal with ASD access acute care system more often than their neurotypical peers due to the multiple comorbidities that are seen with autism. It's our job to ensure that the care that we provide is the best that it can be. Using tools and strategies listed throughout this presentation can assist in making healthcare a less scary place. The first step to doing this is happening right now. It's you attending this webinar so that you understand a little bit more about what autism looks like. I can give you my perspective as a parent, but it's just one perspective. I know families who have it much harder than I do, and they need support. And when they bring their children to a hospital or a clinic or ambulatory care, all of those places, they deserve care that doesn't leave them traumatized, like what happened to Elena. I asked Elena, I told her I was doing this presentation. And so I asked her, what would be one thing that you would want these nurses to know about you as someone with autism? And she said, she thought about it for a minute. And she said, Mom, I think I want them to know that I'm not a label, that I'm a person, and that I need to be treated the same as everybody else. And so if you take nothing away from this presentation other than that, you will make an impact on the patients that you have. Thank you very much. I've included my phone number and my email address here. If you have any questions that we can't answer today, you can certainly reach out to me. I'm very open and willing to share anything that I have regarding autism. If you're a parent with a child with autism and you're on this call right now and you need support, or you just need someone who understands, pick up the phone and give me a call. Sometimes that's all we need, is someone who understands.